You're listening to Project Oncology on ReachMD. On this episode, Dr. John Strickler will share insights on the current state of HER2-targeted therapies for gastroesophageal cancer, which he spoke about at the 2026 ASCO Gastrointestinal Cancer Symposium. Dr. Strickler is a professor of medicine in the Division of Medical Oncology at Duke University School of Medicine and co-leader for the Precision Cancer Medicine and Investigational Therapeutics program at the Duke Cancer Institute. Let's hear from him now.
HER2 has been an actionable target for upper GI cancers for several years now. We learned in 2010 from the TOGA trial that the addition of trastuzumab to standard chemotherapy provided significant survival benefits, so that became a standard of care. Then we went through approximately a decade of negative trials where additional therapies were tried and attempted to improve upon that benefit from trastuzumab. And most of those trials were negative, so we were unsuccessful to kind of move the needle beyond trastuzumab. All that changed in 2020. Right around that time frame, it became clear that the addition of pembrolizumab immune therapy to trastuzumab provided substantial benefit, and then that was later amended to limit that immune therapy to those patients with PD-L1 positive disease. So we've seen that constant evolution towards more immunotherapy strategies. What we have now is a new study finally improving upon that standard of trastuzumab-based treatment, which found that zanidatamab is superior to trastuzumab. So that will become a new standard of care option in combination with chemotherapy, with or without immune therapy. Biomarkers play a very important role in the management of gastroesophageal cancers in particular. We knew in 2010 that HER2 is actionable, and that led to the approval of trastuzumab for those patients with HER2-positive disease, which meant that we needed to test our patients for HER2 overexpression by IHC with FISH if it was an intermediate expressing tumor. Added on top of that over the years, we have other important biomarkers. Mismatch repair from immunohistochemistry can predict for significant benefit from immune therapies. Additionally, we have a biomarker PD-L1. It's the CPS score that we use to predict benefit from immune therapies as well. And more recently, we have Claudin 18.2, which is another immunohistochemistry marker, which is used to predict benefit from zolbetuximab. In addition to that, there are some other rare biomarkers that can be detected from genomic tests, what we call next-generation sequencing panels, to look for other targets of interest where there may be a pan-tumor approval. That could be, for example, NTRK fusions, which may predict benefit from an anti-NTRK therapy. And then there are some other pan-tumor approvals that could impact gastroesophageal cancer. In addition to the established targets, increasingly we're looking for new ways to target KRAS. Occasionally we will see KRAS mutations in patients with upper GI cancer, so that could potentially be actionable one day. But there are a number of other targets in development and therapies in development that may rely upon those tests. For patients who have HER2-positive disease, who progress on first-line anti-HER2-based therapy, we now have an FDA-approved therapy in the clinic that's specifically designed to attack those cancers that become resistant. The name of that therapy is trastuzumab deruxtecan. It's an antibody-drug conjugate. It is an antibody much like trastuzumab, but this one is linked up to a potent cytotoxic payload, a topoisomerase 1 inhibitor payload. So that antibody delivers a potent payload to the cancers and delivers significant benefit over standard of care chemotherapy. We've had this approved for years, but recently we have results from a large randomized trial finding that this antibody-drug conjugate, trastuzumab deruxtecan, is superior to the best second-line therapy we have to offer, and that would be chemotherapy plus ramucirumab. So for those patients that are HER2 positive that progress on first-line therapy, that antibody-drug conjugate is the standard of care and is FDA approved. We now have a bispecific antibody, zanidatamab, which is already FDA approved for patients with HER2 positive biliary tract cancers. That's IHC 3+. And now this drug has been tested head-to-head against trastuzumab in the first-line setting for HER2-positive gastroesophageal cancer, and zanidatamab appears to be superior to trastuzumab head-to-head.
That was Dr. John Strickler discussing the current state of HER2-targeted therapies for gastroesophageal cancer. To access this and other episodes in our series, visit Project Oncology on ReachMD.com, where you can be part of the knowledge. Thanks for listening.